About 3 weeks before I was to graduate from medical school in the spring of 1969, I went down to the student lounge to watch the evening news. That particular night, the program was the Huntley-Brinkley Report. Those of you who remember Cronkite will remember Huntley-Brinkley. And it just so happened that that night, they carried a report from Chicago, where that day the AMA, the American Medical Association, had held a press conference to announce their opposition to the proposed appointment of a Dr. John Knowles, then head of the Mass General Hospital in Boston, as Undersecretary of Health. They were opposing that appointment because Dr. Knowles was advocating something called universal health insurance, and they didn't like that idea. To their credit, by the way, today they do. They've changed dramatically in their position. Had the AMA held auditions to find the worst possible spokesperson for their cause, they could not have done better than the ancient trustee who read a prepared statement, and when he was done and the press started asking him questions, discombobulated so quickly and so dramatically that the AMA handlers had to lead him off the stage. And when they came back to Huntley and Brinkley, they were laughing so hard at this inept performance that they literally had to go to a commercial break to regain their composure. So the next morning, obviously by coincidence, I found in my mailbox at school a form letter from the AMA inviting me to join as an about-to-be new doctor. And on pure impulse, this is not my usual style, I took a pen or a pencil, I don't remember which, and wrote on the form something like, "If what I saw on the evening news last night is any indication of your policy, I do not care to join, thank you." I dropped in the mailbox, never expecting to hear a further word, and to my utter astonishment, a few weeks later, I got a personal letter from the executive director of the AMA describing in some detail their opposition to Dr. Knowles and this policy he was advocating. And again, on impulse, I sent the letter off to this Dr. Knowles in Boston, who I had not met, thinking he would be interested. Well, he was, and he wrote back, and we became pen pals. And when I ended up here in Boston after training, we became friends, and that happened to be at the time when he was part of a mostly Harvard group called Boston Broadcasters Incorporated that took over the operation of Channel 5 in the spring of 1972. And they had determined they wanted to do a little morning program for the public on health matters, and he kind of twisted my arm and asked if I would host it. I was working in the emergency room there. So I'd do that in the morning and then go back to the hospital for the rest of the day, and that's literally how I got started in television, very accidentally. In fact, the way I look at it is if I hadn't gone down to watch the news that night, I probably wouldn't be standing here tonight, right? I mean, don't we all look back on our lives and see those little inconsequential decisions we make, and they turn out to influence us in dramatic ways that we never could have expected. So if I hadn't watched the news and sent the letter off to Dr. Knowles, none of this would have happened. For most of my career at ABC, I reported on new developments in clinical medicine, new treatments, new drugs, new tests, etc. But as we entered this new century, I became more and more intrigued by the issues surrounding the delivery and financing of healthcare in this country, and began to realize, like so many, that those issues were every bit as important in terms of the health outcomes in this country as were clinical developments. And so for the last 5 or 6 years, I've spent most of my time thinking about these issues. I had a chance to do a lot of reading, interview a lot of top experts, and I put together this little book called The Truth About Getting Sick in America 4 years ago. If you find what I say tonight interesting, it's available on Amazon. All profits go to charity, but it's my attempt to try to make some sense of this very complicated, controversial question about what we should be doing with American healthcare. So I'm going to lead you through a little bit of this tonight, just to skim over the surface, and then we'll save some time for questions. The book is divided into 5 chapters. And for those of you who are down in front, I won't be using this that much, but it'll guide us through this. The big question, the big problem, the big fear, since I am a minister, a little bit of a sermon, and the big prediction. So the big question, and this is a question that should haunt every one of us as American citizens, whatever our political persuasion might be. Why does the United States spend more than twice as much per person on health care as the average per person costs of all other developed countries put together? So this year we will spend approximately $9,000 per person on health care in this country. And if you take all the other developed countries in the world, Switzerland, Japan, England, Canada, put them all together, the average per person cost is probably around $5,000, a little less. So we spend about twice as much per person. And yet, we are the only developed country that hasn't figured out how to do universal health insurance. How can that be? Spend twice as much, still haven't figured out how to do that. Why is that? What is it about this country that has prevented us, roadblocked us from doing it? Well, one answer that we often hear is that this country is a lot bigger and more complicated than most other developed countries, and that's true. We really are an ethnically and sociologically and economically diverse country compared to many, but not all, other developed countries. Germany, for example, is a pretty complicated country too. So that's certainly maybe partially an explanation. Another explanation often is that Americans have been raised on the tradition of individualism versus any collective sense of responsibility for all of us. And there's some truth to that. America is a country that developed in the banner of rugged individualism, and the sense of social solidarity that many other developed countries grew up with has not been a rich tradition in this country. Now, some people say we need to spend more money to achieve universal health insurance. That's an answer that is not correct, as we've just pointed out, because we spend already so much more than the average of other developed countries. The problem is we don't spend that money very well. Almost all health economists will say that about a third of what we spend is, and they'll use different words, but the most common probably is, quote, unnecessary, meaning there's no good scientific evidence that the spending of that money makes any real difference in the outcomes. Well, if you realize that we're going to spend 2.7, close to $2.8 trillion this year, a third of that, roughly $900 billion unnecessary, that's a lot of money that could be used more effectively and more efficiently if we could figure out how to do it, and if we had the political will how to do it, which I'll come to later. Now, if we lived twice as long as other countries, of course, then the money, I guess, would be well spent. But don't worry about all these numbers. But the red bars are the 5 top spenders, and we have the lowest life expectancy of those type 5. I'm going to just skip through a lot of these things because they're not that critical. Let me point out, here's another little interesting statistic that tells you that just spending money isn't necessarily going to provide better care. These are the variations in Medicare spending. And if you look at the one on the far left, that's Miami, Florida. A few years ago, that number was up close to, $15,000 per person on Medicare patients in Florida. If you look at the far right over there, you see, for example, Salem, Oregon, about $5,000 per person, about 1/3. No difference in outcomes. Why do they spend so much money on Medicare patients in Florida and so little in Oregon? Well, because there are a lot of doctors and outfits down there in Florida that know how to take advantage of the elderly population. And they run them through a lot of tests and a lot of procedures, and we all know that. We maybe have relatives down there or hear about it. So here's another example of where we spend money without any real sense of whether or not we're spending it wisely or in a worthwhile way. So what's the problem here in this country? Well, the problem, and this is obviously an oversimplification, but it's one way to think about it, is that we have a formula that leads to financial disaster, that is, the spending of money unwisely. On the one hand, we have the expectations of all of us as Americans for health care. And you tell me if you don't think this is pretty accurate about how you feel. I know it's how I feel, how families feel, how Americans in general feel when it comes to health care. We want health care, I've used a bunch of C words to give the flavor of our expectation. We want health care that's convenient. I mean, we're the land of convenience stores, America. And so when we think we're sick, we want an appointment right away that afternoon. Free parking, thank you. We want to be seen immediately. We want care that's coordinated, compassionate, communicative. Who wouldn't want that kind of health care? Those are wonderful qualities, but they take a lot of money and a lot of personnel. Number 3 is really the one that I'm going to spend some time on. We Americans have been raised to worship at the altar of high technology. So we have come to believe that the newest treatment, drug, device, test is automatically going to be the best. It's got to be, because it's the newest, right? And so we love the new stuff, the breakthroughs, the cutting edge that we hear about on the news or read about in the paper. When we get sick, when our family member, that's what we want, because we assume that it's going to be the best. And then, of course, ideally, we want it to be cheap, or better, even yet, cost-free. Somebody else will pay for it. Our employers, many Americans were raised to expect the employers to pay for health care, or the government through its various programs. I've often pondered why it is we get so annoyed when we have to pay even $10 for a copay when we're sick. And I think it has to do probably with some hidden subterranean psychology where, when you go out to buy a house or a car, it's your decision, you want it, you study it, and you know you're going to pay for it. But when you get sick, you didn't want that in the first place, and they have to pay for it. That's really annoying, isn't it? In some sense, it's one of those expenditures of life that annoy us because we really didn't want it in the first place. Whatever the reason, we Americans, we kind of want it all, but we want somebody else to take care of it for us in terms of paying for it. So you have this high level of expectation on the one side here, and then if you look at the other side, you've got all these drivers of healthcare costs who are more than eager to meet those expectations with new products, new drugs, new devices, new tests constantly. Arnold Relman, editor of the New England Journal of Medicine in a 1989, I think it was, editorial, referred to this complex of drivers as the medical industrial complex in this country, playing off Eisenhower's famous military industrial complex phrase. And there's a lot of truth to that. And I could spend an enormous amount of time on each one of these about how they are ready and able to meet our expectations with high-cost products and developments. Doctors, hospitals, drug and device companies, insurers. But I want to say just a word especially about number 6 on that list, because that was my career. And I look back on it now with a much different perspective than I probably had at the time. I thought I was doing God's work in terms of describing the new developments and new tests, new drugs, new devices, and in some cases I was. But I'm going to give you an example where my eyes were really opened for the first time about how this can also be a perverse kind of force. Many of you will remember that in the 1990s, some of the leading experts in breast cancer treatment in this country, the true experts, nationally known figures, started to talk about the use of bone marrow transplants for advanced breast cancer. And we interviewed them, we gave them space in the media to tell their story, and very predictably, women and families afflicted with breast cancer started demanding this new treatment that the experts were talking about. And so the doctors and the insurance companies were inundated with requests for bone marrow transplants, and if they didn't get it, they would sue the insurance companies to force them to pay. And this went on for about 7 or 8 years until finally in 1999 at the national cancer meetings in this country, the ASCO meetings, there were 3 gold standard studies finally done and presented that showed that bone marrow transplants for advanced breast cancer were no better than standard chemotherapy. But in the meantime, hundreds of thousands, probably into the millions, nobody knows for sure, of women underwent this very difficult, dangerous treatment with a lot of side effects, very costly. The studies finally got done, and we stopped doing them almost overnight once we had the data. But we do that all the time in this country. We introduce a new product, a new drug, a new something, and we advertise it directly to consumers. We promote it in the press. We love to talk about breakthroughs. And so you have this marriage of expectation of the benefits of new and high technology with the medical industrial complex pouring out this new stuff, and that leads to this high expenditure per person in this country, and a lot of it unproven, unnecessary, maybe even dangerous in some cases. So, I want to talk for a minute about the big fear because it plays a role in all of this. The big fear in healthcare in this country, articulated in many different ways in many different places, and is that the federal government somehow is going to take over healthcare in this country and ruin it for Americans. And obviously, this has become a political game, playing on this fear. So when I address this, I often ask people to think of an industry in this country that is very private, very competitive in the private marketplace, but under the heavy regulation of the government to the benefit of us all. Quick guess? Not pharmaceutical. They don't allow us to even negotiate drug prices, as you know. Think about the airline industry for just a minute. Tell me this now, really, be honest. When you get on a plane at Logan or Biloxi, Mississippi, or Butte, Montana, aren't you glad there are federal standards about how often that plane has to be inspected and the way in which it must be inspected? And aren't you glad that there are federal standards for pilots and how often they have to be recertified and retrained? I mean, how would you like to get on a plane in some states and know that it was left up to the states to decide how they wanted to do that? Make me nervous in some states in this country anyway. We don't have that heavy regulation in terms of safety in the healthcare industry. And that's why, according to the Institute of Medicine, as many as 100,000 people die every year in this country from medical errors. Now, we don't get too worked up about it because it's not like a plane crashing dramatically. These deaths happen one by one behind closed doors or pulled curtains, so they don't grab our attention in the same way. But in fact, I have come to believe deeply that there is a very important role for the federal government in regulating the standards for healthcare and leveling the playing field, even getting involved in how much we spend and how we spend it. And I will simply tell you that every other developed country in this world, including bastions of free enterprise like Germany and Switzerland, the federal government plays a very strong role in these regards in terms of making healthcare a competitive enterprise, but based on standards that everybody understands and plays by in terms of the same rules. Let me give you an example in Germany, very capitalistic country, as we all know, the leading economy of Europe by far these days. They have 170 plus private insurance companies they call them sickness funds. Not a great name probably, but that's the tradition in Germany. The government sets the rates that these insurance companies will get paid. So they're the same for every insurance company. So they don't compete on the basis of cost. They don't have all these complicated plans with different coverage and different costs that make it very hard for people to understand and choose. It's the same for everybody. But they do compete on the basis of service. So every year, Germans get to choose their insurance company. If they don't like the one they had, if they didn't think the service was good, they can try another one. And there's real competition on the basis of service. So they control costs at the federal level, but they allow real competition in the marketplace in terms of service. Very interesting way to do it. They've done a much better job than we have in controlling costs because of that, and their outcomes are every bit as good as ours and in some cases better. So there are a lot of ways in which I think, and the role of the federal government does vary from country to country, but always it comes down to trying to ensure that there is standardization and control of cost so people aren't left at the mercy of the private system with no controls. Now, I know that's political anathema to many, but I am telling you that I've come to deeply believe that unless sooner or later we have that kind of role for the federal government in our healthcare, we're going to see what we've had happening in the past 4 decades, which is healthcare costs climbing steadily. Most years, 2 to 3 times the general inflation rate. The last couple of years have been uniquely different, and people are wondering why that is, and I think there are a lot of possible reasons. My own prediction is that those costs are going to start going up again in a year or two. The same thing happened when Hillary Care was being debated back in the 1990s, and everybody was paying attention to costs, and they leveled off, you'll remember, for 3 or 4 or 5 years, and then they just took off again. I'm very fearful that's going to happen again. I hope I'm wrong. But the forces, the underlying forces that now are being held under control in some ways, I think can cut loose again. So this is the big fear, and I think we've got to get over the idea that having the government involved in medicine is automatically bad. It obviously all depends on what kind of involvement, and I'll come back to this when I talk about the big prediction at the end. Let me just say another word about comparing countries in terms of what we can learn. Another absolute eye-opener for me occurred back in 1993 at the height of the debate about Hillary Care at that time. And Peter Jennings asked me one night he said, Tim, I want you to do a 4-minute report on world news comparing the U.S. and Canadian healthcare systems. 4 minutes. I said, Peter, can't be done. And his standard answer was, oh, you'll figure out a way. You'll do it. Well, we actually did figure out a way that turned out to be fascinating to me in ways I never would have predicted. We called up the Family Practice Organization in the state of New York and asked them to pick what they thought was a kind of typical 2-doctor family practice. And then we did the same thing with the comparable organization in Ontario over the border, asked them to pick a 2-doctor practice. And once they gave us the names of the practice, we called the practice and said, pick a young family with 2 kids that we can interview when we come. First, we go to Springdale, New York, south of Buffalo, and 2 wonderful young family physicians, really superbly trained and dedicated to their patients. But I quickly learned that in that office, they had the equivalent of 3.5 full-time people who did nothing but fill out insurance forms. 26 different companies they were dealing with at the time. Paperwork, piled up. And then the family that they picked was a young logger, I can still picture them, with 2 children, one of them a 6-month-old. And we got talking about how they managed healthcare costs because he made just a little too much, so he didn't qualify for Medicaid, but not enough to buy health insurance. Everything we looked at their budget went to food and clothing and rent. And so I said, so what happened when your baby was born? And he said, oh, well, my wife was in labor. I sat in the business office for a couple hours and negotiated a 10-year payment plan. One way of doing it. So now we go across the border into Canada, 2 young doctors, excellent doctors, and when I raised the issue of the costs of running the office, they couldn't even understand my question, so I had to explain what we had learned in New York. And she said, oh, we have a woman who comes in 10 hours a week and does all our billing, because it's the same form for everybody. Single payer system, simple administratively. That was kind of an eye-opener for me. I really hadn't thought about that much. I hadn't been thinking about how offices work. And we now know that the overhead for private health insurance is anywhere from 12 to 20% typically, whereas for Medicare, a single-payer system, and I'll come to that at the end, it's about 1 to 2%. So right there, you're talking about a lot of money that we spend on paperwork, which doesn't really have any impact on our health or the outcomes of our health. So that really got me thinking about what we might learn from other countries. Now, Canada continues to control healthcare costs much better than we do, but people have to wait a long time for elective procedures in Canada, no question about it. And, as I said, we Americans don't like to wait. We want it right away, right? So the Canadians have kind of been raised to think, all right, we'll wait, but then it'll cost us less and we'll control costs. For them, it's a trade-off they accept. I don't think we Americans are ready to accept that, but maybe someday we'll have to out of sheer necessity, and I'll come again to that. All right, here's the big sermon, the little sermon, very little sermon. There are many estimates, but probably the best one so far is that about 45,000 people die in this country every year prematurely because they don't have health insurance. Actually, most people think the number is much higher. The way I look at it is, it's very hard for us to say we're pro-life and live with that statistic in a country as rich as we are. It really bugs me. at a moral level. I mean, the way I look at it is healthcare protection is sort of like fire and police protection, kind of basic to the pursuit of life, liberty, and happiness. And we don't think twice about trying to provide fire and police protection for everybody. Why are we so hung up on health protection, basic health care? Well, I talked about some of the reasons earlier, and you can talk about them in the question and answer period. But the sad fact of the matter is that we Americans have been living with this kind of moral deficit, is the way I think about it now, for many years in this country. And to me, when it comes to sickness, serious illness for sure, it ought to be pretty much like burglars and fires in terms of really wanting to do something about it early on to prevent a catastrophe from developing. So aside from the moral issue involved, I think there's a real financial issue involved. And put very simply, unless we're going to get to a point where we're willing to let people die in the streets, which I don't think we will and hope we never will, the truth of the matter is that sooner or later we take care of everybody in this country. But people without insurance have to get really sick first. And then usually they get taken to the emergency room, and then they get admitted to the hospital. And we end up paying a fortune for their care. Whereas if we could have taken care of them early on, in most cases, or at least in many cases, we would have spent a lot less money and been more effective. So if any of us get a bad chest cold, we'll go to our doctor or clinic or somewhere because we have insurance, and if it's bacterial, we'll get an antibiotic and we'll get better. People without insurance tend not to go. They're embarrassed. They don't know how they can pay for it. So they wait, and then it develops into a pneumonia, and pretty soon they're in pulmonary failure. And now they get to the emergency room, and of course we'll take care of them, and we admit them, and they'll go to the ICU, and it'll be a $300,000 bill. So I think both morally and financially, we Americans have to come to realize that it really does make sense to try to achieve at least basic health care, health insurance that leads to health care for all of our citizens. Back in 1810, two Boston physicians were very concerned about people in their city that were not getting health care because they were poor. So they thought we should start a hospital for them. And they sent out this letter to raise money. And in the letter they said, "When in distress, every man becomes our neighbor, not only if he be of the household of faith, but even though his misfortunes have been induced by transgressing the rules both of reason and religion." What they're really saying here is, if you get sick, we're not going to ask questions. We're going to take care of you. Ask questions later. Even if you're not like us, you're not of the household of faith, you're not our religion, even if you brought this on yourself, you were stupid, we're still going to take care of you. That's the moral imperative. This letter got circulated. It became known as the circular letter and led 10 years later to the formation of the Mass General Hospital, and those words are still engraved in one of the hallways there. To me, that's sort of the heart of the matter, that when people are sick, we just take care of them. And we try to figure out how to do it most effectively, most cost-effective, most medically effective. And usually that means the earlier we can get to them, the easier it's going to be and the cheaper it's going to be. So, the big prediction. I mean, I'm really skimming the surface here, obviously. The big prediction. I'm fearful that these forces that I have described are going to take over American healthcare again very quickly. Now, there are a lot of really interesting experiments going on under the aegis of Medicare, under the aegis of some private insurance companies like Blue Cross and Blue Shield. Many of you may have read about what Massachusetts Blue Cross Blue Shield is doing with new insurance programs that are designed to control costs by having a kind of a fixed payment per person, and then it's up to the healthcare and the patients and their families to figure out how to spend that money more wisely. A lot of interesting experiments going on to try to control costs. They may work. They may start to work even on a national level. But if you ask me today to make a bet, I would say I'm fearful that the underlying dynamics that I described earlier are going to take over again very soon in this country and start driving up costs. And if we start going back to the old model where the inflation rate for healthcare is 2 to 3 times the general inflation rate, that's obviously not sustainable. And if that happens, we will face absolute financial disaster in this country because of healthcare costs. And many health economists are predicting just that somewhere in the next 10 to 15 years. If that happens, my prediction is that it'll be pretty much like the banking crisis. They'll have an emergency meeting in Washington, and under the duress of true bankruptcy, or as George Stephanopoulos put it to me